Good evening to you. Wonderful to be with you. And as a physician who attended many of these kinds of functions for years and years, and then we saw the numbers dwindle down, it is great. Isn't it great to be back with a bunch of folks who are really interested in solving the problem? This is wonderful. This is wonderful. You can feel the energy that is going to be so necessary to actually solve the challenges that we face. So I'm honored to be with you, and Tom, I thank you for those kind words. Although I said I was interested in taking questions, I didn't say anything about the answers. So, as Tom mentioned, I serve on Ways and Means and Budget in the House of Representatives. I represent the 6th District of Georgia, which is northern suburban Atlanta. Serving in my 5th term. Before I got involved in politics, I was an orthopedic surgeon for 20 years, and I oftentimes get the question, why did you get into politics? And the real, I know we've got a doc here who's newly elected to the state legislature. Right here. Give him a hand. You need folks of all different stripes, and my story, the short version is that I was answering the call from my state medical society in the late 80s. We had a tort reform crisis just like every other state, and they said, get your white coat and head down to the Capitol, and so I did, and call the legislators out to give them the spiel about what exactly ought to be done for lawsuit abuse at that time. That was 26 years ago. We haven't solved that problem yet, by the way. So I called them out, and I'd never met them before in my life, and I had these wonderful conversations with these delightful individuals who gave me that blank stare back, like, I have no idea what you're talking about. And as a type A surgeon, I said, well, something's got to change, and so we got involved, and one thing led to another, and I served 4 terms in the state Senate, 3 terms in the minority, 1 in the majority, became the first Republican majority leader in the history of the state after the '02 election, and then elected to Congress in '04 and every 2 years since. And what I thought I would do to try to give you a perspective about what's going on in D.C., not that I've got the answers, but I think that there are some hints that I can share with you about how Washington is seeing these issues right now. And I want to talk about kind of the current law, a little bit briefly about the marketplace, what's happening out here where you all are trying your best to make certain that patients are able to be cared for. Touch very briefly on employers' reactions, because I've heard a couple stories recently that are really troubling about what employers feel they're being forced to do because of the current law. Touch very briefly on the states, and then talk about some positive solutions. And we're going to do all that in about 10, 15 minutes, and then I look forward to a few questions. First, thanks for what you're doing. I know that what you're doing is incredibly difficult, trying to make certain that patients are able to be seen and cared for with the highest quality of care. It's really, really difficult. And it's made more so because of what we do at the national level. And I recognize that, and that's an important appreciation, because unless you recognize that Washington is oftentimes making the solutions more difficult as opposed to easier, you can't get to the right answer. So current law, I would suggest to you, is moving forward, and depending on which branch of government you're in, you view it a little differently. If you're in the executive branch, you're cranking out the rules as fast as you can. If you're not on the CMS rule email distribution list, you need to get on it. Because it'll make you feel like a popular person. I mean, they're sending out email after rule after rule after rule after rule. I just got one today that had another 106 ACOs that had been approved by CMS. So they're working as rapidly as they can to implement the law. In the judicial side, in the judiciary side, there are a number of other contests that are kind of working their way through the courts. The one that I would urge you to take a peek at and follow most closely is one that's coming out of Oklahoma. It's a contest that says the law didn't stipulate that any individual who received their health coverage through a federally subsidized exchange would be able to receive any subsidy. The law doesn't say that explicitly. And so Oklahoma is saying if the law doesn't say that, you can't do that. That, I think, will wind its way through the court in this term. I think you'll see the Supreme Court rule on that in this term. And then at the legislative branch, what we are trying to do is to see if there are any ways to be able to make the law work better for you and for patients. And I'll touch on some of those solutions. Secondly, what's going on out there in the marketplace? I would suggest to you that we've distorted the marketplace even more than it already was before. And I want to mention a couple specific areas. One, may hit home with some of you, the MLR, the medical loss ratio, the provision that was included in the law. It's a provision that says at least 80 or 85% of the premium dollar has to be utilized for clinical care or medical care, which sounds great, right? Sounds great. I want 85 cents on my dollar used to take care of me, and you do too. The problem with that is that the definition of what is medical care isn't in the arena of who's taking care of the patient. It's from on high. So if, for example, Washington decides that what you think helps you provide the highest quality care or the highest quality coverage for the people that you are covering isn't what Washington thinks, then, oh, guess what? That doesn't fit into that 85 cents, and therefore that gets squeezed. And that's why one of the unintended consequences, I believe, or maybe intended, but I think unintended consequences of these kinds of rules and laws, it's having non-medical people making medical decisions, and I think that's a very, very dangerous place to be, and we're going to kind of work through that. MLR repeal is one of the things that has bipartisan support, and we'll continue to work on that. Second, the medical device tax. This was one of the provisions to be able to pay for the law itself, 2.3% tax on gross receipts, not profit, gross receipts for companies that make medical devices. Again, the problem is, what's a medical device, right? If it's not, and the definition that's apparently been settled on is that if it's not sold at retail to the consumer, then that's a medical device. So if it's not just implants, it's not just the kinds of things that you think about when you think about a medical device, it may in fact be things like dental chairs. It may be things that you don't even imagine could be a medical device. If we move down that road where we are punishing people for innovating in the system, then we will have less innovation and therefore less quality care. What are the employers doing out there? I shared with you that I've heard some remarkable stories over the past literally couple days. I visited a fellow who has a car dealership in our hometown, and he said that 68 part-time employees who used to work between 30 and 35 hours a week are now going to be limited to 28 hours a week because then they don't come under the law. Talked to somebody else who said they had 46 employees in their business, and they were ready to expand, but they weren't going to, because of the law. If you get over 50, then the law begins to apply. So the consequences of the law itself are changing the way that people are dealing with their businesses and their employees. So I think that one of the take-home messages I would give you is that this whole system is dynamic. And dynamic not necessarily in a good way, but dynamic in that things don't stay the same. When we change the rules, you all respond trying to make the best of it, and you may do what Washington thought you were going to do, or you may not. And if you don't, then that means that the consequence or the intended effect doesn't actually occur. How about states? This is where I would urge you to kind of follow the number of states, and you're in the midst of it right now with your legislature and with your governor attempting to decide whether or not to increase or expand the Medicaid eligibility. Your state is one of 32 states now that have decided not to create a state exchange. The majority of states not to create a state exchange, which puts it all on the federal level. And your state is currently one of 34, I believe, that have decided or haven't decided whether or not to expand Medicaid eligibility, which has huge consequences for all of you, as you well know. And the reason that states are considering not expanding Medicaid eligibility, as you also know, is that you don't know how long that federal subsidy lasts. How long does that 90% hold? Is it just the 4 years or 5 years that's described, or is it beyond that? And when you don't know, it really becomes a question of whether or not it is your fiduciary responsibility to not then take on that extra work. Let me just touch on positive solutions, because I think the dynamism that's happening right now, we're going to see in the current law, we'll see the system unfold in a way that I think will be less responsive to patients than the American people will tolerate. So the accessibility of Medicare patients to Medicare physicians is going to get to be a real challenge. The affordability of health coverage is going to get to be a real challenge. The innovation and therefore the quality is going to be challenged. So I would suggest to you that what we're going to see play out if the current law isn't modified is that the American people are going to get sick and tired of what they see then as a system that is not responsive to them. And it is incumbent on each and every one of us to make certain that we have positive solutions to offer as an alternative. And to that end, let me touch on a couple different areas. I think that it's important to appreciate that you can solve many of the insurance challenges that the bill tries to solve without putting Washington in charge of these definitions. For example, the opportunity to cover pre-existing illnesses. You don't need to dictate to people that they must cover it in order to provide coverage for folks with pre-existing illnesses. One could, if one were creative and supportive of the dynamism of a marketplace, say, let's create robust pooling mechanisms for people to pool together so that you can pool with somebody else and millions of other people literally across state lines to be able to get the purchasing power of millions so that any one individual's health status doesn't run up the costs of their health coverage for anybody else. If you think about it, the folks that are challenged with pre-existing illnesses and injuries, and they are, and it's a terrible problem, they're the individuals in the small group and individual market. They're not the folks in the ERISA plans. They're not the folks on Medicare. They're not the folks on Medicaid necessarily. And that's about 18 million people. So we could allow those individuals to actually pool together in ways that allows them to purchase the health coverage that they want for themselves and for their family, not that the government wants for them. A real important solution that is patient-centered. Secondly, the whole issue of portability. You ought not lose your insurance if you change your job or you lose your job. That's a holdover from really a bygone era when we worked for one business or one company forever and ever and ever. And that's a real simple one to solve. If we were simply to allow individuals to own and control their health coverage, regardless of who's paying for it, so that if they change their job or they lose their job, it goes with them, just like their 401k plan, then you immediately solve the problem of portability, and then they could plug it in wherever they ended up with a new job or a new situation. So there are wonderful, positive solutions that I hope we concentrate on as we move forward. Two more quick points, and then I look forward to a question or two. First, I heard a small discussion about health IT in the other room. Health information technology is absolutely vital for us to become more innovative, become more responsive with a system of health care. However, I would suggest to you that the government's role right now in health IT has been to define things like meaningful use, which for those of you who are in the real world know that it's neither meaningful or useful to use them. I would suggest that the role of the federal government in health IT is to define and stipulate the highway upon which we're going to drive so that any system can communicate with another system. So that you know that if you purchase an electronic medical record or health record or health IT system, you know that you can communicate with anybody else out there. We're all driving on the same road, instead of saying what it must include. And if you do that, then you all, the market, gets out there and robustly brings about different products, and people, you and patients, gravitate toward the product that is most responsive to them. Finally, we waste huge amounts of money in health care in this country, huge amounts of money. I would suggest to you that the most important way that we waste, the largest way that we waste money in this country, is rarely talked about in the context of wasting money, and that is the whole issue of defensive medicine, the practice of defensive medicine, the things that I did, the things that every single physician does to you, to your family, and to every single patient in this country. It doesn't necessarily harm a soul, but its sole purpose is so that if we're ever called into a court of law, we can look the judge and the jury in the eye honestly and say, I don't know what you expected me to do because I did everything. And then show them everything that you did, when in fact everything wasn't necessary to either diagnose or to treat the patient. But it's that everything, that delta of everything, is the practice of defensive medicine. And Jackson Healthcare, which is a company that has done a lot of research on this, estimates that it's 1 out of every 3 healthcare dollars. Y'all are bright folks. That's $800 billion of literally waste in our system. Even if they're off by a factor of 50%, $400 billion is a huge amount of money. Now, the routine process that we go through as good conservatives, good Republicans, we say, what are you going to do for malpractice, lawsuit, abuse? Well, we'll cap non-economic damages. There isn't a single state in this country that has a cap on non-economic damages that you can point to with evidence that shows that it has decreased the practice of defensive medicine. It holds down malpractice costs a little bit, but it doesn't do a thing for the culture of the practice of medicine. I believe we need to be more creative about our solution for lawsuit abuse, for liability reform in this country. I believe that if the doctor does the right thing, if the physician, the provider follows specialty society guidelines for a given set of symptoms or a given diagnosis, that must be able to be used as an affirmative defense in a court of law, so that you get a bar that you have to really leap over in order to prove liability. If the doctor knows that there's a safe harbor, if he or she understands that if they do the right thing, that the likelihood of them being found liable in a suit, we will, in fact, change the culture of the practice of medicine and get to huge amounts of savings in our healthcare system. So there are positive solutions out there to the challenges that we face. It's a dynamic marketplace right now, without a doubt, and I commend you for the work that you're doing. If I had to challenge you to do one thing before I take your difficult questions, I would challenge you to increase your political involvement. We can't do what we do without you telling us what we need to be doing. It's that first look when I went and talked to that state senator, when I pulled him out of the state senate and told him about the concerns that I had about caring for patients and got this blank look back. You need to go get some of those blank looks and then make it so that those blank looks are no longer blank. If you participate in this process in a way that educates the decision makers, I promise you that we can get to the right answer as it relates to taking care of patients in this country. Thank you so much. God bless you.